I'm going to talk a little bit about preoperative planning, what the surgeon needs to know. This is actually one of my favorite topics to talk about. What's interesting, this is a presentation I probably made up about 12 years ago, so parts of this are 12 years old and not much has changed, but there are some new aspects when we start to think about the implants that we use and the new techniques that we have. So really what I was going to talk a little bit about is how I plan presently. What values are important when we think about anatomic total shoulder arthroplasty? And probably one of the most important questions, which is new way of thinking, is for me is that when do I convert to a reverse and how can I simplify this for myself? This is actually one of my favorite sayings when you think about it. Failures don't plan to fail, they fail to plan. It's really true. As surgeons and therapists, we never want to cause harm to our patients. We want to do the best for our patients. So if there's techniques that we can do to improve our outcomes or decrease our complications, I think the onus is on us to learn those techniques and put those techniques into practice. So what is the benefit of preoperative planning? Certainly, preoperative planning helps me. It helps me be more efficient. It helps me anticipate the challenges during the operation. It allows me to think of the implants I'm going to be using. It certainly speeds up the operation. By that part, so it also is actually beneficial to my patient. I'm going to hopefully decrease the risk of early complications and provide them some value. It's actually helpful to my hospital too, because the nurses that I work with, they know what implants they're going to be using. They have those all ready. They have the instruments ready. And hopefully through this presentation, I'll demonstrate how it's going to be valuable to you also. So why to plan? Probably one of the most important questions to ask is what happens when we don't plan for surgery? And so you can see these are cases. This is a case that was referred to me. This is actually my own case, and this is another one that was referred to me. These are all easily preventable complications. The first case, the glenoid was put in retroverted. If preoperative planning was done, the surgeon would identify this as a 45-degree retroverted glenoid. Maybe a standard anatomic implant is not the best idea. The second case is my case. Is 2008. I was experimenting with the bio-RSA. You can see I put the base plate in superiorly inclined, and I translated the base plate high, and look at the pretty impressive amount of notching that I have, which should not happen when you do a good bio-RSA. In the last case, you can see this was a very conservative head cut. If the surgeon would have made the time to actually identify how thick that head cut would have been, this would have been a preventable problem. So why do you plan? So why I plan is it allows me to identify the pathology. It allows me to think of the operation. So if you can see here in the top right, this is a traditional B2 glenoid. And once you start to think of this as a B2 glenoid, you think of all the challenges that you've heard people talk about. You know, B2s are retroverted, they have bone loss, they have posterior subluxation, so you start to think of all of these things. It allows you to assess the bony erosions, and we know with the B2, it's traditionally posterior inferior, not directly posterior. It allows you to assess the soft tissues. Most of the planning software now have soft tissue windows. With the soft tissue windows, you get an idea of how much fat infiltration has occurred. Is there atrophy involved? Because we know that soft tissues are so important in our decision-making process of when we convert from an anatomic to a reverse shoulder replacement. Identifies the challenges. I'm going to have to, if I choose to do an anatomic in this patient with a B2, I'm going to have to address that bone loss. I'm going to have to address that subluxation. And these are challenges that I'm going to have intraoperatively. And it also allowed me to identify the challenges or limitations in the implants I have available. And this is important. So if all I had available to manage this patient was a standard glenoid, there's only one technique or one or two techniques I can do. I can just ream the high side all the way down, or I can put the implant in retroverted. So if that's not something that falls into your philosophy on how to manage an anatomic total shoulder arthroplasty, you may choose to have augments available, or you may say, in this case, I'm going to go right to a reverse shoulder arthroplasty. So it allows you to certainly identify those limitations. Appropriate sizing. This is also very important, especially in the extremes. I think all of the implants that we have today, even the ones that are out there, they're very good for the average sized human being. But if you have a very, very small person or a very, very large person, they're not well designed. So you can see this is Kareem Abdul-Jabbar. He probably has a 58 to 60 millimeter humeral head, and most companies don't offer a humeral head past 56 millimeters, so certainly things to consider. This is a patient of mine. He's about 6'8" tall, so I don't know how much that is. That's over 2 meters tall, and that's a 52 millimeter humeral head, which at one point in time was the largest humeral head offered by this TESS implant. So you can see it's grossly undersized for this particular patient. If I would have thought about this case and preoperatively planned this case ahead of time, I would have had larger size implants available, and also allows us to put those implants in potentially the best possible position. So what are the facts when it comes to preoperative planning? We know that CT scans are better than x-rays. We know 3D CT scans are better than 2D CT scans. And we also know that thinking about an operation or planning has never been shown to be detrimental. It's only of benefit to you as the primary care provider and also to the patient. So there's many different types of planning software out there. I think all of them have their pros and cons. There's no one planning software that's better than the other. I think it's really important just to identify which one you like or which company you choose to work with. So in the process, before we get to preoperative planning, we always have to do, with the history, physical examination, we get x-rays, a CT scan, and then I put them through the software. And kind of the overall view is what I'm trying to determine is the diagnosis. And with the diagnosis, we know there's going to be very traditional diagnoses that we manage with arthroplasties. You have osteoarthritis, cuff tear arthropathy, massive rotator cuff tears, and so on. And if you look through these classifications and these diagnoses, there's very traditional ways to manage all these. And so once I've classified them, then I'm going to actually look into them in a little bit more detail. So here we have the Walsh and Favard classifications. So let's look at the Walsh classification first. What are we going to do? Are we going to do an anatomic or are we going to do a reverse? If I look at the A1, there's going to be some controversy there. So if an A1 has minimal bone loss, which it should, it's a good candidate for an anatomic. However, the soft tissues come into play, and that's where I decide if it's going to be reversed based on, is there an associated rotator cuff tear? The A2 for me is a reverse. If they have medialization, I'm not going to address that with an anatomic. Those patients get a reverse. The B1 and the B2 is also a challenge. Those are the ones where preoperative planning can be very helpful to determine if the implants that we have available can manage that, or do we have to go to reverse. B3s and Ds for me are also reverses. I think with a B3 with the amount of erosion posteriorly, I think a reverse is probably the best option. And with a D, with the anterior subluxation potentially, I think also a reverse is a very good solution. With the Favard, it's very easy. Every one of these is a reverse. We know with massive rotator cuff tears and cuff tear arthropathy, that certainly would be the standard of care now. So when you're thinking about anatomic total shoulder arthroplasty, there are certainly, there's evidence-based guidelines and there's also personal thoughts, and you kind of mix those together, and then you're going to have these limits of what you're willing to accept when you do an anatomic total shoulder arthroplasty. So for me, if I can accept my limitations with the implants that I have available in 2024 and the techniques that I have available in 2024, I will do an anatomic total shoulder arthroplasty. If I cannot obtain those threshold values in those patients, I'll do a reverse shoulder replacement. So the question is what are my evidence-based limitations and personal limitations? Here they are, and I've actually put a little asterisk here because this is based off today, because this changes as more literature comes out. So for me to do an anatomic total shoulder arthroplasty, they have to have an intact cuff. I personally believe that we have to correct the retroversion to under 5 degrees of retroversion. That's a personal thought. It's not evidence-based. Evidence-based would probably say at least correct to 10 degrees of retroversion. Inclination, the evidence would say minus 10 to plus 10. My personal is 0 to 10 degrees of superior inclination. Over 90% backside seating is something that I aim for, ideally 100%. And if I need an augment, I'm going to use the small or the medium-sized augments. There's 3 different companies out there. They all have a small, medium, large. Typically, the large ones are a little bit too much for me. So if I can't correct with a small or a medium, I'm going to a reverse shoulder replacement. So let's play this video. So this is a traditional B2 case and how I plan it. So I'm looking through it. On the far left, I see this is about 20 degrees of retroversion. I don't think about the retroversion number to begin with. I think about it at the end. So is my implant going to be able to correct that? So here we're looking at the soft tissue windows, some atrophy, a little bit of atrophy, look at the tangent sign, but still an intact rotator cuff with some mild degree of subluxation. In this patient, if you look at the AI algorithm, it predicts an anatomic at 55%. So it's a reasonable, there is some controversy here. So let's go ahead and plan the glenoid. So if I had only a standard glenoid implant, I don't believe I'll be able to correct this deformity to under 5 degrees or under 10 degrees, maybe your number. So here, if I have to correct it or put this in where it lies, it's going to be 15 degrees retroverted, which for me is unacceptable. Let's just play with the rotation, increase the size. And so what I see is, in this case, I'm going to try and augment now. I'll try the 25-degree wedge augment. That's my upper limit, but many of you may have 35 degrees as your upper limit. For me, if it's 35 degrees, it goes to reverse. So here, that's that 25 degrees. I get over 90% seating. We can adjust the inclination, still keeping it within 0 to plus 10. And I think this is probably a very good plan for me. maybe move the glenoid a little bit down. So because I can correct this to under 5 degrees of retroversion, between 0 and 10 degrees of inclination, I think this is a reasonable case for me to conduct an anatomic total shoulder replacement. If it falls out of that, I'll go ahead and plan the reverse. So here's the operation. Now the key is we've learned that preoperative planning is helpful for guiding surgery. But more importantly, if you really want to execute with some degree of precision and accuracy, we probably need the enabling technologies. And so the enabling technologies would be something like a patient-specific implant, optical navigation, mixed reality navigation, which is coming down the pipeline, robotics. These are ways that certainly in the next 5 or 10 years, I think we're all going to be using. I mean, we use robots to make our watches, we use robots to make our cars, robots to make our food. It would make sense that robots may eventually help us during operations too. So in this particular case, we're going right to the glenoid. There you can see a very sclerotic neoglenoid, and there's a cartilage still on the paleoglenoid. Relatively small paleoglenoid, but I had preoperatively planned this, and I felt that I could get a 25-degree wedge implant in. And so to execute my preoperative plan, I'm going to use a patient-specific guide. I don't use these all the time. I use these probably about 10 to 15% of my cases, in the cases that I really want to correct with some high degree of precision. And so then we'll go ahead and adjust the rotation. And then once we adjust the rotation, we're going to start preparing the glenoid in a very traditional manner. So here we're going to prepare the anterior portion of the glenoid to get 50% coverage from the paleoglenoid. So I'll ream. And then once I've gotten that 50% coverage, now the one challenge that we have with patient-specific instrumentation right now is we don't have a depth of reaming. I think certain companies do offer that, which is actually quite a benefit. So here we'll adjust the degree of reaming. So if it's a 35-degree implant, in my practice, I won't use that. So I'll use a 15 or 25 degree. And now we'll go ahead and prepare the backside. We'll bring that in. And then once we've prepared the backside, we'll go ahead and drill the peripheral holes and place in the implant. So this is a very traditional all polyethylene glenoid implant, which actually, if you look at the Australian Joint Registry, has an excellent outcome. So I think, personally, I still believe in 2024, the all polyethylene seems to be the gold standard with the longest amount of literature behind it. Certainly the new hybrid glenoids are coming in. I think I'm optimistic that those are also going to be very good in the future, but we don't have long-term data on them just yet. All right, there we go. And so then once we've done that, we'll put our cement in. And there's our trial implant. And so you can see in this particular case, I corrected it with a 25-degree wedge. Give it a hit. And there we go. And we'll just speed along to cementing it. And there we are. So then I'm going to just put it in the final implant. There we go. And we'll move along. All right, so what is the future of planning? As I mentioned, I think the future of planning is definitely going to be robotics, mixed reality navigation, optical navigation. So this is a case that I just did recently where we used mixed reality navigation to determine where our implant positioning is, and you can go ahead and put in your guide pin and hopefully have some degree of accuracy and precision. So in summary, I think preoperative planning is important, whether it's just looking at x-rays and CT scan, eventually go into software. I think it helps us become better surgeons. Understand what your limitations are for total shoulder arthroplasty, and when those limitations are surpassed, I think we've been shown over and over again that reverse shoulder arthroplasty is a great bailout operation. It's probably going to become the gold standard in the very near future. Thank you.